Yes, sir, we can.
We can? Sure.
Yes, sir.
So very good evening to all our esteemed doctors who have joined here. Very good evening to Dr. Patel, our moderator and convener for the day, and very thanks to each and every of our esteemed panelists. Allow me to briefly introduce myself. I'm Dr. Parthasarathy from the Medical Affairs team of Macleods. I handle multiple therapy areas here. I myself have been a clinician who transitioned as an emergency medicine physician into medical affairs. So it always gives the pleasure for the medical team here to connect back to our own clinicians, our own alma mater. Also, thanks to Mr. Kanabar from our esteemed Gujarat team for championing and pioneering this session. So, Mr. Kanabar, a great kudos to you. So, very good evening and warm welcome. I now hand over to Dr. Charmi, who would introduce the slides. But before we go on for the session, just one small note from our end is that what we are looking for is a free discussion between all the panelists who have joined. The slides are not the main focus. The slides are just contextual. So post the slides, what we are looking for is active participation as a free exchange of ideas for questions that are put forth by our convener and moderator, Dr. Patel, and a free exchange of ideas between all our esteemed panelists. So on the same note, Dr. Charmi, over to you for the introductions.
Very good evening, one and all. So we have with us Dr. Paras Patel as our moderator for the day. Sir is director at Health Aura Medical Clinic, Merlin, Pentagon, Ahmedabad. Sir did his MBBS from SPKS Medical College, Waghodia, DNB Medicine from Pune Hospital and Research Center, IDCCM from Sterling Hospital, Ahmedabad, and Sir has published various papers in international journals and has published 10 abstracts till date in prestigious forums. Along with Sir, we have with us our panelists, Dr. Rajendra Moti, Dr. Dhrumil Patel, Dr. Henil Shah, Dr. Vaibhav Kothari, Dr. Priyank Kapadia, Dr. Anand Nair, Dr. Mitul Barot, Dr. Kaushal Gandhi, Dr. Balram Patel, and Dr. Sandeep Contractor. We welcome you all, and now I hand over to Dr. Patel.
Yes, so thank you very much, Dr. Charmi, and thank you very much, Dr. Parthasarathy, for warm introduction. And thank you, the McLeod Pharmaceuticals team, for this wonderful interactive session. So we shall proceed ahead with the scientific content of today's lecture. And so the slides are visible now?
Sir, they are not full screen. They are visible, sir, but not yet full screen.
Now?
Sir, Paras, you need to share your entire screen. Instead of sharing a particular tab only, you need to share your entire screen so that the slides mode will be visible to everyone. You can simply stop share first.
Okay.
And yeah, click on share screen now. And
Yes.
Select the screen option instead of selecting a particular tab. Select the entire screen option, the very first one. Okay, now you can do the slideshow.
Okay.
And
Done?
there you go. Perfect.
Yes, sir.
Yes. Okay. Thank you so much. So sorry for the interruption, but we shall proceed ahead. So today's agenda is particularly regarding the role of dapagliflozin, which we now use frequently on day-to-day basis. Once it is off patented, the charges are less. It is available at each and every corner of our nation, so we can use it frequently. And most of us we know the benefits of using this SGLT2 inhibitor, which is dapagliflozin. So we have a brief introduction over why we use dapagliflozin and what is the burden of diabetes in our nation at nationwide as well as the international level. So as we see, the particularly this hyperglycemia or the diabetes, it is increasing very rampantly over the last few decades. And if we project that if we have in 2019 we have 88 million patient of diabetes in Southeast Asia, the rise is over 115 million in 2030 and will be 153 millions in 2045. So will be 74% increase in the cases of the diabetes. And if we see over the worldwide, it will be 50%, more than 50% increase in the cases of the diabetes, which is a very huge case. So we keep monitoring the patient, we keep screening the patient for the early diagnosis of diabetes, so that we get good result, we get good control over the sugar. But still the number of new cases of diabetes increases very rampantly. Right now, as we know that diabetes is not only the control of the sugar, but prevention of complication is also our duty. Hence we keep study about the diabetes and its related complications. So diabetes and the elevated blood sugar level, these are associated with approximately double the risk of cardiovascular disease. Now individually there are a lot of factors in personal life that is putting patient towards the cardiovascular risk, like tobacco, smoking, alcohol, physical inactivity, dyslipidemia. These are the parameters other than diabetes that puts the patient to the risk of cardiovascular. But in absence of these factors, only a single factor, that is diabetes. Diabetes alone is a major cause of cardiovascular morbidity and mortality, which we will discuss today. So only if we consider the cardiovascular disease, so there is a 32% prevalence of cardiovascular disease among the diabetic patient. Amongst that cardiovascular disease, if we bifurcate and if we look forward, if we have the coronary heart disease, that is 21%. Myocardial infarction rate is 10% and stroke is 7.6%, that is the cerebrovascular accident. So it is a huge number. So we have since last 1 year or since last decade, we can say there are a lot of studies which has been done for the cardiovascular outcomes, and various drugs have been studied, particularly on the basis of this data, that diabetes alone is a major risk factor for the cardiovascular morbidity and mortality. So and the another parameter which we should also take care is about the renal health, that is the kidney health. So as we can see from this slide, cardiovascular death or cardiovascular disease, it affects 32% of all the patient with diabetes, and diabetes alone is associated with 3 to 4 fold higher for the all cause and cardiovascular mortality. So if we look for the CV mortality and morbidity, diabetes alone is responsible for 3 to 4 fold, and it is approximately more than 30%. If we look for the chronic kidney disease or the CKD patient, that is chronic kidney disease, then approximately 1 in 3 adult of diabetes will end up with one or the other renal issue in near future, that is as per the predictions. And every 24 hours, that is 170 people with the diabetes, they begin treatment with the renal failure. So again, there are a lot of hurdles and there are a lot of pitfalls as far as these renal issues are concerned. People, they don't monitor the sugar level, they don't monitor the creatinine level, people don't monitor the urine albumin create ratio. So there are multiple issues as far as the follow-up rate of the diabetic patient is concerned, and these comorbidities and these complications are concerned, right? So we are specifically today we will discuss about the cardiovascular health and renal health as far as the diabetic patient are concerned. So there is a need of a drug that can handle both the issues with single molecule, with a single mechanism of action that will help in controlling the sugar, that will also give benefit for the heart, that will also protect the kidneys. So we have the molecule that we will discuss in further slides. So this is a interplay, this is a very busy slide, but this is a interplay between why and how the pathophysiological mechanism is responsible, and it increases the risk of cardiovascular morbidity, mortality, and also the renal health in the case of diabetes patient. So in the center we have factors like hyperglycemia, insulin resistance, hyperlipidemia, obesity, hypertension, high inflammation markers, and oxidative stress. So all these factors, they are associated with increasing risk of myocardial fibrosis. They will affect the LV contractility, so there will be loss of contraction of the left ventricle. There will be subclinical left ventricular myocardial dysfunction, so that we called as LV dysfunction, that will put the patient at risk of developing heart failure, and ultimately patient will have premature death. Again, atherosclerosis and LV hypertrophy directly associated with hypertension, that will also add up to the cardiovascular morbidity and mortality in such patient. So we have this circle on the right side of the slide, that is myocardial dysfunction. So there are multiple factors, they will attack the heart from various mechanisms. So one is dyslipidemia, one is smoking, then sedentary lifestyle, high blood pressure, insulin resistance, and hyperglycemia. So we need to control all the parameters at a time, so that we can save the person's heart from getting morbidity and mortality. So the primary agenda of today's talk is to keep the heart safe and to keep the kidneys safe. So these are the link how diabetes and other risk factors are associated, and it increases the risk of heart ailments. Now, this is ominous octet. As we all know, we must have seen this slide many times. So there are various pathophysiological mechanisms that is leading to hyperglycemia, right? So first is the beta cell, that is impaired insulin secretion from the pancreas beta cells. So, and to counter that, we have different molecules, like we have insulin and we have sulfonylureas that will promote the insulin secretion from the beta cells. Second, we have islet cell, that is alpha cells. So there is increased glucagon secretion that will promote the hyperglycemia. To counter that, we have GLP-1 analogs and DPP-4 inhibitors, which are widely studied in last decade. Then we have increased hepatic glucose production. To counter that, we have metformin, which is wonderful molecule, and that is now nearly more than 70 years it is available, so we have good experience. Then various neurotransmitter dysfunction is associated with hyperglycemia. Then we have decreased glucose uptake. So in the muscles there are glucose transporters, so this glucose uptake will be less. To counter that, we have thiazolidinones, that is pioglitazone, which is available. Then we have at the kidney level, we have increased glucose reabsorption, that is promoting the hyperglycemia. To counter that, we have SGLT2 inhibitors. And then we have increased lipolysis. So to counter that, we have DPP-4 inhibitors. And so these are the decreased incretin effects. So these are hormonal effects occurring at the intestinal level, and that is contributing to hyperglycemia. To counter that, we have two molecules, that is one is GLP-1 and second is DPP-4 inhibitor. Okay, so now let's keep house open for the discussion. My point is, we all know that there are these 8 mechanisms are there that is contributing to the hyperglycemia. So I would like to have a word with you, with all the panelists, that which one mechanism. So you have to speak only, you have to tell one mechanism which is more contributing to the hyperglycemia, right? So there are all these mechanisms, we know they are responsible for hyperglycemia, but you can tell one which you feel, or which you, as per your study and experience, is affecting more and it is leading more to hyperglycemia. So we can have participants, we can unmute the participants from the technical team, if we can unmute, and let's keep session open for the discussion.
Dr. Goti, you can, Dr. Rajendra Goti, sir, you can feel free to share your expert insights.
Yes, sir. So please give your opinion regarding this ominous octet. Which one mechanism you feel more or directly correlating with the risk of hyperglycemia and directly associated with hyperglycemia? So, yes, sir. Yes, good evening, sir. Dr. Goti,
Good evening.
sir. Yeah. So, sir, my point is this, whether, sir, you can see the slides. This is, yeah. Okay. So this is ominous octet. So my point is, there are 8 mechanisms that are responsible for the hyperglycemia, as we can see, right. And you must agree with all these mechanisms. So personally, with your experience, with your information and knowledge, which one mechanism you feel it is more and more strongly associated with hyperglycemia? That is my point.
Okay.
So whether it is pancreas, kidney, brain, intestine, liver, or lipids?
That is pancreas.
Yes. So definitely, sir, pancreas are more culprit, and because so you can add up to this, sir, if you wish.
Hello.
Yes, sir, Dr. Goti, sir, you can add up to this. You can add up to this. Yeah. Okay. So as sir rightly said, it is pancreas, and we do agree with the sir's experience and answer, because see, the diabetic patient, most of the time it happens that they get diagnosed very late. So the thing is, hyperglycemia, this will have that is high blood sugar, that will cause glucotoxicity, right? So that will cause glucotoxicity, and that high sugar level is not good for the health of beta cells. Hence, the beta cell won't be able to sense the blood sugar level to the appropriate level, and hence the function of the beta cell will get hampered over a period of time. Now, these things must be going on for months or years, because when we diagnose patient, they will come with the leg pain or weakness, and then we do the sugar, it will be around 300 and 250 like that. So that will be the eye-opening day for the patient, that, oh, I am having diabetes. So already the pancreas will be compromised, and will be there must be some compensation going on in the pancreas. But as sir rightly told, that pancreas is directly associated with the hyperglycemia, and this is one of the mechanism. So in that case, if there is high glucose level persistently for a long time, which is unaddressed and untreated, so this hyperglycemia will affect the function of beta cell, and hence the insulin secretion will be hampered, and again that lack of insulin will again contribute to hyperglycemia. So this will be a vicious cycle. Yes, so high sugar and poor insulin, poor beta cell function, poor insulin will add up to high sugar. Again, high sugar will affect the beta cell function. So as rightly sir told, so perfectly fine, sir. Anything else you want to add, sir?
Dr. Gandhi also wishes to add.
Yes, yes,
Gandhi,
please
welcome your
welcome.
thoughts, sir.
Yes, we welcome Dr. Gandhi, sir. So the point is regarding the
Sir, you're
ominous
mute.
octet.
Gandhi, sir, you're mute.
Sorry.
Yes.
Yes, so kindly unmute. Yeah.
Actually, hyperglycemia is combination of all these mechanisms.
Yes,
One
sir.
more mechanism which I want to add is glucose absorption. We are Indian. We have food which is high in carbohydrate and which is absorbed in intestine. So alpha glucoside inhibitors are the one more mechanism which has to be added here.
Yeah.
And, two things, which is impaired insulin secretion, increased glucagon secretion, increased hepatic glucose production, and other mechanisms. Two things which are there, we can't control diet of patient. We explain everything, but still there are hidden sugars which are there in food, and glucose absorption both in kidney and intestine has to be inhibited in Indian context. That's why these two drugs are very important in our context, in our patients. Along with other things.
Yeah, definitely. And thank you very much for sharing your experience, sir. And so multiple mechanisms do play a role in putting patient in the high sugar basket. And as rightly sir told, that it is intestine that is to be addressed along with kidney for the reabsorption of the sugars. Definitely, thank you so much, sir. So we can move ahead with other participants if they have some if they can put some insight over this ominous octet.
Dr. Paras, I'm Anand Nair here.
Yes, sir. Definitely, most welcome you, sir, and good evening. So yes, sir. You can proceed ahead, sir.
Yeah, actually, what I think is that to begin with, the main cause of developing diabetes hyperglycemia would be a combination of impaired insulin secretion and insulin resistance.
Okay, sir.
So insulin resistance may include decreased glucose uptake, increased hepatic glucose production, increased glucagon secretion. So there could be imbalance in both secretion as well as resistance. So in some patients, one may weigh more than the other. Okay.
Yeah.
So the other factors, they come into account later on. Once hyperglycemia develops and then it persists. Then increased glucose reabsorption in the kidneys, decrease in insulin. These are effects of hyperglycemia that later on develops.
Later on develops, yes. Yes, yes, definitely, sir. There, thank you for your valuable feedback, and it is very important that there is a interplay between the impaired insulin secretion and insulin resistance, and both the things will be simultaneously going on, and there is imbalance, as sir rightly told. And once the insulin resistance is more, then you will have more sugar level, and that will again affect the that will again impair the sugar this insulin secretion from the pancreas. So it is always a interplay between, and so hence we call it as a metabolic derangements rather than only a diabetes, because with this impairment in the mechanisms, there will be other comorbidities also. So like lipid profile derangement and all those things. So again, these things are clubbed, and it is interplay. Definitely, it is interplay between multiple factors. Okay, so we have another participants here, so we can have their insight over this slide.
So just to say, so we still have a lot of slides to go. So you can
Okay.
involve the participants as
Later
and
on.
Yes. Sir.
Okay, okay. So we'll move ahead with the slides, right?
Yes. Sir.
Yeah, so moving to next slide. So now this is the evolution of the treatment, and we keep changing the guidelines over as per our experience. We have American Diabetes Association, we have European Association, then we have American College of Clinical Cardiology. So all these parameters, they used to keep changing the targets and keep changing the strategies. So initially in 2009, the HbA1c was the main target. It remained main target till 2015, and now later on, since last 4 to 5 years, we have more focus on the cardiorenal events, right? Because as we came to know that with normal HbA1c also we have more cardiovascular morbidity and renal issues, and that is associated with morbidity, mortality, and cost and daily. So all these factors are associated. So now since last 5 years, we have many studies that are based on cardiorenal outcomes. Strategy previously was lower the better, then we came in 2015 lower the better, but without hypoglycemia and without weight gain. And now we have therapies that work on multiple mechanisms. So we need to keep in mind the blood pressure, the cholesterol level, and drugs for the control of sugar that should be has been proven safety for the cardiovascular and the renal issues. So that we will come to know. So again, this is similar slide. So initially, till today, we have first line of agent, that is metformin. Unless contraindicated, we should go ahead with the metformin. Then if HbA1c is under control, that is okay. If it is not under control, then we add up the second molecule. So as per the different mechanisms and as per the different guidelines, we have different molecules preference. So we have both two drugs, that is one is SGLT2, second is DPP4 inhibitors or GLP-1. So these are equivalent, GLP-1 versus DPP4, and second molecule is SGLT2 inhibitors, right? So either one we can add as a second agent as per the patient profile. So we have to individualize the therapy in that. Now we'll have short look over the mechanism of the SGLT2. So this is the normal anatomy of the nephron. So where we have glomerulus, proximal tubules, loop of Henle, distal tubules, right? And we have two receptors, that is SGLT2 and 1. So once we have the glucose filtration from the glomerulus, SGLT2 and 1 both will try to absorb the sugar. So most of the sugar will get absorbed, out of which predominant work will be done by the SGLT2 receptor, and less amount of job will be done by 1. And and the left out sugar will be excreted in the urine, so which will be very minimal. Now if we provide a drug that will inhibit the SGLT2 receptor, so what will happen? Let's see. If there is a glucose filtration at the glomerulus, if SGLT2 receptors are blocked, then there is only 10% of reabsorption. 90% reabsorption from the SGLT2 inhibitor will not be done, and hence the more amount of sugar will be released in the urine, and hence the blood sugar levels will get under control. So this is roughly main mechanism as far as the SGLT2 inhibitors are concerned. So this is from the 2020 guidelines about the novel therapies for the cardiovascular risk outcomes in patient with type 2 diabetes. So as far as this SGLT2 inhibitor, the class of molecule versus CV benefit is concerned, so we have grade 3 reduction in the MACE prevention. Heart failure prevention was grade 3. Weight loss was also seen. Then we have renal disease progression prevention. Then mode of administration is oral. So in our pipeline of the medications, we try to get oral medication that is easy to take and more convenient. Then, and the last part of the slide is that is the prompt use of alternative classes. So there are few concerns as far as SGLT2, they are not absolutely safe. So there are the canagliflozin study was done, that is Canvas study, where they found that canagliflozin associated with the peripheral arterial disease and increased risk of amputation. So we try to avoid in those class of patient. Second, there is increased risk of genital candidiasis, increased risk of diabetic ketoacidosis, increased risk of fracture. So in those patients, we try to modify the mechanism of action, or we choose alternative molecule. So this is the slide regarding the SGLT2 inhibitors and role in glycemic control and beyond. So as far as kidneys are concerned, they get a good therapeutic target, so which is important part in the ominous octet, which we discussed previously. Second is a need of OAD that has CV safety and survival benefit. And so these are the OAD class recommended by the latest guidelines. So this is again the mechanism. So it is similar. So we have all this benefit from the SGLT2 inhibitors, that is decreased plasma glucose level. It reduces the weight, it reduces blood pressure, uric acid level, and it reduces the glomerular hyperfiltration, which is causing the diabetic kidney disease. And this is again a similar slide, that how it reduces the risk of steatosis, that is NAFLD, then heart failure risk, and myocardial fibrosis. So these are the various mechanisms by which SGLT2 inhibitors, that is having the, it reduces the intravascular volume, it reduces the blood pressure. So cardiac preload and afterload will be less, sympathetic activity over the heart will be less, and parasympathetic activity will be more. Then so this is how the discovery, or how the SGLT2 class has been origin. So it is a busy slide. So we had these SGLT2 inhibitors approximately 10 years back. And that is initially they were contraindicated in the early renal failure, but now we can use till the eGFR is less than 20. So it is having good metabolic control, risk factors control, MACE reduction is there, CKD benefit, and heart failure benefit. So we'll have the studies in next few slides. So we can ask to the well, let's keep house open for the discussion. And how often you use dapagliflozin nowadays? Means now it is available everywhere at cheaper rate, and with good quality we get easily available, and we can easily convince the patient about use and benefit of the dapagliflozin. So Dr. Rajendra Goti sir, if you can unmute yourself and please share your insight.
Hello.
Yes sir, you are audible. Please go ahead sir.
Okay, sorry, I was seeing patient. So
yeah, okay. Yeah, so my point is ki, now dapagliflozin is available easily at each and every corner of our nation. Right. It is available at cheaper rate. So right. How often you introduce your patient to dapagliflozin?
Miss, very frequently. I used almost 70 to 90% patient to my patient dapagliflozin, and right now we can use. Sorry.
Yes sir. Yes sir, you are audible. Please go ahead sir.
Okay. Yeah, I'm using it is very frequently.
Okay. So you are more, means you are getting more comfortable with the use of dapagliflozin, more confidence.
Initially, it was some patient was complaining about gastritis or abdominal pain, abdominal cramps. So okay, I was using very cautiously, but nowadays it is not a problem.
Not a problem. Okay, so we are more comfortable in prescribing dapagliflozin, looking into the benefits the patient will get at cheaper rates. Okay, and the drugs are also easily available. Okay, so if we have Dr. Gandhi is here.
Doctor, sir, we also want to hear from Dr. Contractor, Dr. Kapadia, Dr. Dhrumil Patel, and Dr. Vaibhav Kotari.
Yes, sir. Please, panelists, please participate and try to give your insight. How frequently you use dapagliflozin and what is the level of comfort you have achieved?
Dr. Sandeep Contractor. Yes, sir.
Hello.
Yes, sir. You are audible. Please, sir. Go ahead.
Yeah.
Very good.
In our routine practice, usually I don't use in 80 to 90%, but at least 40-50% I use, especially those who are having a higher blood pressure, you are having the cardiac comorbid conditions are there, I usually prefer to go with an dapagliflozin with an SGLT2 inhibitor, with an DPP4 inhibitor. And if at all required, we can add on other things. But usually hypertensive patient, cardiac conditions are there, patients are obese, in which we have to require a reduction in the BMI. In that patient, we prefer for the dapagliflozin. And also we see that they
Dr.
don't have
Contractor,
a history of pyelonephritis or cystitis in the past.
Dr. Contractor, pardon me. Sir, can you on your camera? Actually, our compliance team would want you to on your camera. Just for a few minutes, sir. Thank you. Thank you so much, Dr. Contractor.
Okay.
Yes,
Am
sir.
I visible?
Yeah,
Yes,
you are visible, sir.
You are
Okay,
visible.
okay. So usually what we do is we have the comorbid condition seen. If at all we have an obese patient or the patient is having a cardiovascular problem is there, then in such cases we prefer to go for an DPP4 this SGLT2 inhibitor, preferably with an DPP4 inhibitor.
Okay. So wonderful insight, sir. You need to cater both the mechanism of drugs, that is SGLT2 with DPP4 inhibitors, and as per the comorbidities, you will select the molecule. Definitely good, sir. We can move on with another panelist.
Yes, sir. So we would also want to hear from Dr. Vaibhav Kothari, Dr. Dhrumal Patel, and Dr. Priyank Kapadia. Dr. Kothari, over to you.
Yeah, but you can unmute yourself, sir. Yeah,
thank you. Yes, very nice molecule. All SGLT2 inhibitors, especially dapagliflozin nowadays has available in cheaper price. So in country like India, where half of the patient they are they need some economical molecule. So in that case, yes, dapagliflozin, to write dapagliflozin, the indications are many more. As you told in previous slides that nowadays we are looking at CV mortality, MAGE reduction, and renal risk reduction. So if you look at any of the study, MPAREC trial, CANVAS, DAPA HF trial, or DAPA CRF trial. So what every trial says that the SGLT2 inhibitors, especially DAPA and MPA, they are very good at risk reduction of heart failure and cardioprotective, renoprotective, reducing risk of hospitalization with heart failure and CKD. So in those patients who are having comorbidities, who are at a high risk of cardiorenal disease, they, according to me, they must be getting dapagliflozin. If they have any of the contraindication, let's say recurrent UTIs or history of pyelonephritis or any evidence of diabetic ketoacidosis, because some patients, they come slow type 1, they are insulinogenic, they may end up in ketoacidosis with DAPA. So those patients should always be excluded. But the rest of the things, yes, definitely it should be used as second line. It has been in guidelines so that the dapagliflozin should be added in almost all patients who are at high risk of cardiovascular or renal disease, like obese patient or having any past history of myocardial infarction or any dysfunction. So they must have, unless it is contraindicated.
Okay. Very good insight from Dr. Vaibhav Kothari. We can move with other panelists. If they are available,
Yes,
we
sir.
can have your insight.
Dr. Dhrumal Patel.
Yeah, Dr. Dhrumal Patel, sir.
And Dr. Mitul Barot. Dr. Dhrumal Patel and Dr. Mitul Barot. You can share your insights.
Yes, you can unmute yourself. Okay,
Dr.
so
Dhrumal Patel and Dr. Mitul Barot. No worries, sir. So I think we can proceed.
Yeah, we can proceed. We can
Yes.
once they unmute, we can have their experience in.
Right,
We can interrupt in between, right? Yeah.
Yes, sir.
So so this slide again, it is important as far as dapagliflozin for the glycemic control is concerned. So now more than 250 clinical studies have been done as a initial therapy and as an add-on to the metformin or sulfonylureas, or as an add-on to the insulin, or in combination with the GLP-1 RA. So dapagliflozin again in the CV death, CV disease and the heart failure, more than 35 trials are done, and more than 12 trials are available as far as the renal health is concerned. So what is the clinical evidence and why we quote regarding the benefits of the SGLT2? So this is the CV trial as far as dapagliflozin is concerned. So this was a very big study, and approximately 17,000 participants were there, and as we can see, the dapagliflozin was compared versus placebo over a period of say 4 years, and the hazard ratio was found to be 0.8%. So there was 17% reduction in the risk of cardiovascular morbidity and mortality when dapagliflozin was compared over placebo. So this is very evident from the study, and we have very robust data as far as this study is concerned. Again, this is a very important study about the renal composite. So what factors were seen during this study? So there is more than 40% decrease in the eGFR. Then there is a new development of new end-stage renal disease, that is ESRD, and death from renal or cardiovascular cause. So as it is evident from the graph that dapagliflozin was compared with placebo, and there was 24% reduction in all these morbidity and mortality. So again, it has proven very wonderful results. Now these are the this is a very busy slide. It is I will tell you in brief regarding the HbA1c reduction. So HbA1c initially it was kept in target, but it is still a target. It is still a target. We have now multiple trials, we have multiple studies, and everywhere we used to keep HbA1c as one of the marker, because it is definitely associated with risk of complications. And the idea of controlling of sugar is one is to control the sugar, and second, more importantly, is to prevent the patient from development of complications, for which HbA1c is a easy tool which can be done in laboratory at the cost of 500 rupees. So HbA1c will never lose the importance. HbA1c reduction with SGLT2 is very important. So from the slides we can see, if we use only 5 milligram of dapagliflozin, there will be 1.1% reduction in HbA1c, which is very important. If we use dapagliflozin 10 milligram, then it is 1.4% reduction in HbA1c. Then as we add on the different molecules, that if we use dapagliflozin with DPP4 inhibitors with metformin, then we have percentage reduction of HbA1c is nearly between 1 to 2%. So it is a very good data and very good improvement as far as the glycemic control is there. So the drugs are capable to achieve good amount of HbA1c reduction, that is evident from the slide. Second, this is the weight reduction. So the study was done over a period of 24 weeks, where dapagliflozin was compared with, and it was added with the other molecule, and the percentage of weight reduction was compared. So a person on insulin with placebo, there will be no effect. If we use dapagliflozin with insulin, then again there will be reduction of approximately 3.7 kilogram of the body weight. Like that, we have different molecules. So if we use dapagliflozin with metformin with sitagliptin, then there will be maximum reduction of the weight as far as the studies are concerned, and as far as the mechanisms of these drugs are concerned. Now so third parameter, so one is HbA1c reduction with SGLT2, which we have seen. Second is the renal health that we have seen. Third is the CV benefit we have seen. Fourth is the weight reduction that we have seen, and the fifth point is the systolic blood pressure, right? So these drugs, they do address the systolic blood pressure, and that we can see if we use dapagliflozin, there will be 4 to 5 millimeters mercury of reduction in the systolic blood pressure. If we add up metformin, then there will be more than 5 millimeters of mercury reduction in the systolic blood pressure, right? So this is again important study, that is dapagliflozin. It was the objective of the study was there to have the combination of other oral hypoglycemic agent along with dapagliflozin for the reduction of HbA1c, reduction of blood pressure, body weight, and reducing the risk of reducing the incidence of hypoglycemia. So we have to add a molecule that should not increase the risk of hypoglycemia, that should not increase the weight of the patient, and that should not increase the blood pressure of the patient. So all these parameters have been taken care, and the study clearly says that dapagliflozin combined with other OHs could effectively reduce the HbA1c and the body weight without increasing the incidence of hypoglycemia. Then this is DAPA-HF trial, which is very important. So now these studies, so there are various parameters that were studied as far as the dapagliflozin and cardiovascular benefit is concerned. So one was the risk of myocardial infarction, second coronary heart disease, the third is the heart failure. But more robust data were there as far as the heart failure was considered, and single, that is one admission of patient, one hospitalization because of heart failure, that is associated with lot of cost, lot of morbidity, and recurrence of that patient for admission with heart failure, that also increases. So the studies have been designed and have been important, and these parameters have been taken into care, that is to reduce the frequency of heart failure. So rate of hospitalization because of heart failure, that should be less, and that molecule is the most important molecule as far as the diabetes control is concerned. So as we can see from this slide, there is 30% reduction with the use of dapagliflozin as far as rate of hospitalization for the heart failure is concerned. And again, there is also definitely benefit from the mortality benefit, that is death from the CV causes also reduces by 18%. This is important study as far as the renal health is concerned, that is DAPA-CKD trial. So it was done in approximately 21 countries where India, and there were many centers from India also, and approximately 4,000 participants were there. They were receiving maximum tolerated dose of ARBs, and the objective or the primary outcome was considered regarding the declining GFR, development of ESRD, and the death from renal or CV causes. So this is very good data and very promising result as far as dapagliflozin is concerned. That is approximately 40% reduction from all these outcomes were noticed compared with the placebo. So again, this is Emperor reduced and DAPA-HF trial. Then again, this is similar slide regarding the use of dapagliflozin. So then the era was there that in non-diabetic patient, if we use dapagliflozin, then what is the benefit? So the benefit was there in non-diabetic patient also. So now this molecule has become important molecule as far as cardiologist prescription is concerned, irrespective of diabetes status. So they definitely reduce the risk of heart failure. They definitely reduce the myocardial LV remodeling. They definitely improve the myocardial contractility, and they reduce the risk from development of coronary heart disease. So even cardiologists, they are more convinced about the use of this molecule as far as DAPA-HF trial is concerned. So and the study was done in that study, 1/3 population was non-diabetic and 2/3 were diabetic, and all have shown the benefit. So this is the primary endpoint, that the hazard ratio was 0.82, and the dapagliflozin has seen clear-cut benefit over the placebo. So relative risk reduction was around 14%. So then again, there is one more clinical evidence, that is from the DELIVER trial, that is regarding the frequency of the heart failure events, and that is hospitalization from the heart failure or urgent hospitalization visit. So we can see dapagliflozin has seen good benefit over placebo, and approximately 12 to 20% reduction is there from the cardiovascular. Now again, if we control all these parameters, then ultimately we control the metabolic syndrome. So metabolic syndrome will have sugar, that is hyperglycemia, hypertension, dyslipidemia, obesity, and this inflammatory markers will be raised. So all these parameters were studied with the dapagliflozin, and there was good benefit as far as reduction in waist circumference is concerned, systolic blood pressure reduction is concerned, LDL reduction is concerned, and triglyceride reduction is concerned. So this is evident from this study. So let's put house open for the discussion. If we have participants, they can unmute themselves, and they can they can share their experience and insight regarding the use of dapagliflozin is concerned.
Yes. So I believe we are anyway towards the end of our slides. I think we can unshare. You can unshare the slides because you have presented so well till now.
Yeah.
And you have actually covered all the evidence, sir.
Yeah, so most of the evidence has been concerned, has been covered. So only, so this was the EMPA-REG, Canvas, Declare, and Virtus CV trial, and this was the from the NEGM. It was recently published, and so we have all the benefit, that is MACE prevention, CV death, and hypertensive heart failure. So all the trials have given promising results. So SGLT2 inhibitor, in particular dapagliflozin, has shown promising results. And again, this was the renal outcomes from these trials. So they have the renal composite outcomes they were considered. So that is also good. So this is just the briefing about the initiation. But now I don't think this slide has to be discussed, because the clinicians, panelists are clinicians, and they must be using this drug now since more than 6 months or more than 12 months. And they very well, they use this molecule and they know how to begin. So we can have the insight, or we can have the panelists to share their experience as far as use of dapagliflozin in multiple ways. Anyways, on diabetic, non-diabetic, there are multiple indications now.
So there are a few thoughts which you brought out very beautifully in your conversation. You brought out the perspectives of diabetes. You brought out the perspective of the ominous octet, and a very wonderful point also mentioned by Dr. Nair was the perspective of insulin resistance as well as
secretion,
a challenge with insulin secretion. And an important point was, even in the DCCT study, they did show that the moment a patient was detected as diabetic, he has already lost 50% of his beta cell mass. So that again brings a very responsible balance to the conversation, where it's a pathophysiology of multiple origins and not possibly just one organ, as you rightfully put forth in your talk. So also a thought from our end was, what are the key challenges to prescribing dapagliflozin in clinical practice? Is it just a urinary tract infection, or there are other challenges also in clinical practice that exist?
So if we have panelists, if they want to answer, the house is open for discussion. And
we would love to hear from Dr. Priyam Kapadia. Dr. Vaibhav Kothari has spoken. Dr. Priyam Kapadia, Dr. Mithul Barot, and I believe we yet have to hear from two of you esteemed doctors, Dr. Mithul Barot and
yes, if you can come up
Dr.
with your
Priyam
insight.
Kapadia.
Yeah, we would like to hear from the panelists. If you can share your experience, and if you can answer this issue.
Dr. Mithul Barot.
Hello.
Hello.
Yes, you are audible.
Good evening, everyone. I just see this presentation. Sorry, I didn't recall the question or topic.
Dr. Barot, the question was basically, what are the challenges in your clinical practice, or in clinical practice in general, to initiating or maybe maintaining the patient on dapagliflozin? Is it just UTI, or there are also reports of euglycemic ketoacidosis, diabetic ketoacidosis due to poor selection of patients, maybe especially in the insulinopenic patients? So are there such kind of challenges that exist in the real world in clinical practice? Your insights and take on the same.
Right. So I think if we talk about only dapagliflozin, SGLT2 inhibitors, then definitely right now the cost is main constraint. When we got a good molecule with lesser price, then challenges are reducing. With flexibility of dose we had, like 5 mg and 10 mg. So there are also benefits with that, because initially I usually start with the 5 mg dose, and once patient tolerated, then I uptitrated up to 10. So if we notice a fewer side effect with 5 mg, then we can manage according to that also. Most common side effect, as you said, like UTI and genital infection, these two are the commonest side. But we can manage with the increased fluid intake and hydration and counseling the patient. So I think in current scenario, dapagliflozin had no other issue, and flexibility dose is available even with CKD patient. We can use. Weight reduction is the good and fast, most ever good benefit which every diabetic patient required to reduce his weight. So yeah, it's a good option for diabetic obese patient. So I think it's a good molecule.
Dr. Kapadia.
I only have one contraindication which I came because I look forward for many pre-operative and peri-operative patients. So usually we should stop it before the any kind of operation which needs catheterization for longer time, like spine surgery, cervical spine surgery, in that kind of patients, we should stop it for at least the time when patient is on catheter. I just wanted to tell you this thing.
Wonderful and very responsible insight.
Yes, and very this is being done on day-to-day practice. So this insight has to be taken, and everybody should keep in mind regarding this important issue, because once you are doing catheterization, that puts the patient to UTI, and you are giving medicine that will add up to the UTI. So a person is admitted for one purpose and will get another issue. So which definitely we won't like to happen as far as
usually what happens is that patients are discharged in 1 or 2 days or 3 days, and then the physician will not be coming to see, because they will be discharged by the operating surgeon, and they will tell that you continue whatever medicines you are taking, and then sometimes it is missed because dapagliflozin and this group of drugs are used frequently nowadays. So then the patient comes with high-grade fever and UTI and sepsis. So I have come across this type of complications in last 1 year, 3 to 4 patients who needed prolonged hospitalization because of pyelonephritis. So I thought that this might help us to reduce the side effects of hyperglycuria.
Yes. Definitely.
Thank you.
Wonderful. Yeah.
Thank you very much, Dr. Kapadia. Very useful and very patient-centric insight. Thank you so much.
So
we would also like to hear from Dr. Nair.
Yeah.
Anand Nair, sir, your esteemed insights on the same, sir.
Hello.
Yes, sir.
Yes, sir. You are audible. Please go ahead, sir.
Yeah, actually, I would differ using dapagliflozin in patients who have predominant insulopenia, because they come with polyuria, polyphagia, and weight loss and all. So I prefer using this first time. Start with sulfonylurea and metformin, and later on, when the hyperglycemia under control, then slowly I gradually shift to dapagliflozin. That is one thing. Secondly, urogenital infections, they are quite common, but I've seen that with proper counseling, and once the patient follows proper hygiene, then that is not an issue. And definitely, elderly patient with low blood pressure, with tendency of getting dehydration, those patients we should always be cautious while using dapagliflozin. And patient with acute heart failure, so they are more prone to ketoacidosis. So should wait till the patient stabilizes. Patient get discharged from the hospital before putting on SGLT2 inhibitor.
Yes, sir. Wonderful. All these points will be kept in mind, because all these factors are to be taken in care as far as the clinical practice is concerned on day-to-day basis. So acute heart failure, no need to rush and start the dapagliflozin, stabilize the patient. And second, the sugar control. So this SGLT2 or the dapagliflozin, they will not start their action from the next day. They will not control the sugar on the next day. So once the sugars are getting under control, then we can introduce this molecule to have the lateral benefits, that is over the CV benefit, renal benefit, weight loss, blood pressure reduction, and good control of HbA1c. So very wonderful experience and very good thought from Dr. Nair.
Sir, I would also want to ask an unbiased opinion from all our esteemed clinicians here. And we all agree that every patient is different. No guideline can actually tell you what to do when it actually comes in front of a challenging patient. So each of your experiences will be considered valid and completely satiating for the Indian scenario. A wonderful point that was also mentioned in the talk right now was heart failure. So just a thought is, so if you have an ADHF patient, an acute decompensated heart failure, who's come to the ICU, you stabilize them, and later actually, you want to start off the patient on guideline-directed medical therapy. So among the 4 pillars that you have, be it an SGLT2 inhibitor, or an ARNI, or a beta blocker, or an MRA, what would you choose to start off with first? What are your thoughts on the same? Because I was just having 2 different streams of thought. We heard Professor J.V. McMurray talk about starting SGLT2 inhibitors from on one end, because SGLT2 inhibitors would actually not reduce the blood pressure too much. So it allows the patient that. But as you also rightfully said just now, in a diabetic patient with a heart failure who's already at a risk of ketoacidosis, that might actually be counterproductive. So your variable takes and this on the same, sir. Is there any way we can stratify patients separately? So if you have a diabetic patient, what should you think differently? If you have a non-diabetic patient, should you think differently? Your thought and everybody's thoughts on the same.
Yes. So we can have the panelist opinion first.
Yes, sir.
Yes. So we have
Dr. Rajendra Goti, sir.
Yes, sir. Yeah, Dr. Rajendra, sir.
Okay. If patient is diabetic and with heart failure, we can go for dapagliflozin. Means first we should stabilize the patient, and we can go with dapagliflozin. And if patient is not non-diabetic, we can use other means anti-hypertensive and diuretic for the control of heart failure. And Ditor-E means yes.
As a diuretic. Noted,
Yes.
sir.
Yeah.
Dr. Anand Nair. Yes, sir. So your take on the same.
Yeah, actually what I think, I would prefer ARNI above all if the BP blood pressure permits, definitely. And if the patient is diabetic, I would like to add SGLT2 inhibitors.
Right.
So the 4 pillars has to be combined. We can't do any one. So according to the patient circumstances, we have to react accordingly. But ARNI would be my first choice if the blood pressure permits.
If the blood pressure. Thank you, sir. Dr. Mitul Bharot and Dr. Sandeep Contractor. Or Dr. Vaibhav Kotari and Dr. Kaushal Gandhi too can pitch. Dr. Vaibhav Kotari?
Yes, you can unmute yourself. Yeah.
As Dr. Anand said, rightly said that it is you have to add everything. You cannot miss something because everyone has their own mechanism. And,
Noted.
But yes, definitely in diabetic patient, if patient is not having any contraindication to write dapagliflozin, and yes, definitely I would also go for dapagliflozin in those patients. Rather, study says that even non-diabetic patients, they benefit from dapagliflozin in heart failure is as good as in diabetic patients. So if not contraindicated, definitely I would go with dapagliflozin in early phase once they are out of their emergencies.
Just our last question for the day is Dr. Patel, sir, you beautifully showed that slide where you also spoke about pleiotropic effects in NASH.
Yes,
One epidemic which is actually bombing for the future, wherein we have scant therapies, very low quality of evidence. The only proven drugs till date, as you all rightfully know, are vitamin E and pioglitazone. Vitamin E in the non-diabetic subgroup and pioglitazone in the diabetic patients. The GLP-1 receptor agonists are trying to generate evidence in the same. Obeticholic acid failed in its trials from the safety perspective, despite showing certain parameters on reduction in fibrosis. So, sir, where do you see a future for SGLT2 inhibitors? Of course, right now the evidence is less, it's scant and anecdotal. But from clinical practice, what is your take, sir? Because if you can give us any insights, we can suggest clinical trials to take this accordingly. Your take on the same, sir, as a last and responsible question.
Yeah. So the point is regarding the incidence of NASH. So why it is increasing? Because in our day-to-day follow-up of the diabetic patient, what we do is we check the fasting sugar, postprandial sugar, we do HbA1c at frequent intervals. Then we do check the urine sugar level and urine protein level. Then we do check the creatinine, and then we also add up SGPT as far as the liver health is concerned. But the problem is SGPT will not increase in case of NASH in early stage. So most of the time this happens that the diagnosis of NASH will remain delayed or will not get diagnosed. So, and the patient once at least see, if we see once in a year, if we advise the patient to do fundus examination, if we tell them to do USG abdomen, so the sonography or the ultrasound will tell about the fatty liver. Now, fatty liver, so how much liver is fatty, how much is fibrosed, that we cannot get from the sonography. So ideal test to have the early pickup of the NASH will be liver fibroscan. Now there are different machines available. The PK value is there. So if it is more than 12, it is alarming. If it is between 8 to 12, it is not good. If it is below 6, it is normal. So liver fibroscan is very important tool. So just a part of experience that we have now, we now push our patient and we do advise them to do liver fibroscan at least 6 monthly interval to have the early pickup of the NASH. Because what will happen that it is a non-alcoholic condition. So, and once it develops, but diabetes is directly associated with non-alcoholic steatohepatitis as far as the metabolic derangements are concerned. Once NASH will be there, it will put the it will increase the risk to develop the liver cirrhosis and liver malignancy and death, early death because of liver injury. So the important thing or important message is to do liver fibroscan in asymptomatic diabetic patient with normal SGPT. We should do liver fibroscan at twice in a year or at least once in a year, which is available approximately 3,000 to 3,500 rupees in our city. And a few gastroenterologists, they do keep camp and they do it at free of charge also. So the more important thing is to diagnose NASH early, and then we have these molecules, that is vitamin E, then we have pioglitazone, then we have there were studies around the use of saroglitazar also for the SGLT2, and now we have this our dapagliflozin or SGLT2 inhibitor as far as the NASH is concerned. So definitely looking at the mechanism or the multiple ways the SGLT2 are acting, it will definitely show some promising result, and we are definitely looking into a thing that can prevent the progression of NASH to liver cirrhosis. So the idea is to do the proper workup, that is liver fibroscan, to diagnose NASH early. Second, to do the markers, that is hepatitis B and hepatitis C. Now, if hepatitis B is positive, then that is more culprit to develop the liver injury rather than diabetes or alcohol. So in that case, we can, if it is negative, hepatitis B is negative, we can vaccinate the patient and we can reduce that risk of developing liver injury from the hepatitis B infection. Again, hepatitis C, if it is positive, that is treatable with sofosbuvir, and there are multiple antivirals which are available. So once we get, so diagnosis of NASH should be early, then the other parameters that causes the liver damage should be addressed and should be found and should be treated and managed properly. And ultimately is the sugar control, and this SGLT2 inhibitor, as it is evidenced from this slide, it will definitely reduce the steatosis. So we want a good molecule, that is SGLT2 inhibitor, that will try to reduce the progression of the steatohepatitis. So it will definitely show promising result as far as the mechanism is concerned. And along with it, weight reduction, because obesity is again related with the NASH, and that is the strong correlation. So we definitely want a person to lose the weight to get in the normal BMI range, and definitely avoid the definitely do diet as far as the lipid profile is concerned. That will keep the lipids under control, because that is again a factor that will progress the NASH. So we in the India, what the patient perspective is, they don't want to do anything. Everything should be done with the medicine, which is not possible. Right. So that is not possible. So they have to also understand the pathophysiology, and they have to understand that what are the factors that will damage my liver other than diabetes. So there will be alcohol, there will be obesity, there will be poor lifestyle, there will be physical inactivity, there will be poor diet. So all these factors which patient has to control, that they have to do. Rest SGLT2 will do.
Wonderful, sir. Very wonderful and clean, clear, practical insight from your end. So So I think we have finished the end of our session, and we would love to give the vote of thanks from our end. So thanks to each and every one of you esteemed doctors. We are very sure that the unfiltered exchange of ideas that has occurred here would be of use to the organization, as well as we are very glad that we have been a podium to connect with clinicians, wherein you all have managed to connect with each other. A special thanks from our end to Dr. Paras Patel. Sir, an honor to host you, and thank you for taking the session in such a wonderful light, not just a rote presentation of slides, but also from the perspective of taking the slides, discussing it clinically, with ultimately clinical translating endpoints that would be useful for all. I finally hand over to Mr. Narendra Kanabar, without whose help actually this meeting would not have probably been organized.
Yes.
Mr. Kanabar, over to you for the final vote of thanks.
Really, thank you very much for all the doctors for participating and giving your best of the views on dapagliflozin for the future terms and in current clinical condition in all the aspects. I really thank you very much for Dr. Parthasarathy to guide on the right way for the events, and Dr. Charmi to start off the session. Really thank you very much. We can end the session. Thank you very much and wishing you good luck.
Yeah, so from my side, again, I will express my gratitude to McLeod Pharmaceuticals and all my dear colleagues and panelists, those who were available for this wonderful meeting, sharing their experience and giving clear insight as far as the use of dapagliflozin and the present scenario of diabetes and what practical challenges they face in their practice. They have shared it clearly. So, and thank you everybody for joining the meeting and giving your valuable time, because time is money in today's era. So time is sharing time is more important than again anything else. But and very good support from the technical team, very good support from Vishnu Bhai, from Dr. Parthasarathy, then Narendra Bhai is there, and Dr. Charmi.
Thank you, sir. Thank you very much. An honor to host all of you. Yes. Thank you all. Very good evening.
Yeah. Good night and take care of your health. Yeah. Bye-bye.
Good night, sir. Thank you very much.
Yeah. Good night.
Informations. Shall I close this meeting, sir?
Yes.
Yeah. Thank you. Thank you very much, sir. So
Himanshuji, it's Himanshuji?
Yes, correct. Yes. Hi, Parthasarathy. Himanshu this
side. Sirji, thank you so much. Wonderful, and thank you for the immense support from your end. Apologies, मैंने आपका नाम भी लेना भूल गया. आपके बगैर
नहीं ऐसा नहीं